Recently, we published our work using ultrasound to map out perforator flaps, and it's been really working very good to isolate perforator flaps and locate and actually not only see the anatomy, but the functional aspects of the perforator, and it's really made us our use very easy. And you could see that the ultrasound actually has many advantages, such as you could actually know about the physiology and just basically have real-time knowledge. However, there's some learning curve aspect to it. So from using these kind of ultrasound for perforator flap surgery and microsurgery, we started to explore using ultrasound in lymphedema surgery. And when we think about lymphedema surgery, one of the widely used mode to treat lymphedema is lymphovenus anastomosis. And basically, the goal is to reestablish the physiologic drainage from the lymphatic vessel to the vein. So the components of the LVA is basically knowing about the LVA vessel and also having as much information about the vein as well. And if you think about it, the ideal lymphatic vessel that we want to have is basically a functioning lymphatic vessel where there's still a lot of lymphatic drainage happening through the lymphatic system. And also, if possible, have a large lymphatic vessel to work with, which makes the anastomosis much easier. And there are multiple modalities to map lymphatics, as the other speakers have just shown you. The MRI really works great. I like to do MRI as well. It really shows where the dye uptaking lymphatics are. LymphCT scan, basically see the overall flow of the lymphatic system in the limbs, but it doesn't really give you a lot of specific information. It just gives you a crude idea on overall functionality of the limb. You could also use radioisotope that is frequently used for in cancer surgery to detect cancer spreading to the lymph nodes. However, again, this doesn't exactly tell you exactly where the lymphatics are. It just gives you a general idea on the flow or even the flow time from the distal aspect of the limb to the proximal limb. ICG is probably the most popular modalities that is being used, but we do use quite a bit of the ICG almost routinely in all lymphedema patients. But the biggest challenge in using ICG is that the penetration rate is only about 5 to 10 millimeters. And this is why in a lot of instances, when you see this splash pattern, especially in advanced stages like late stage 2 or stage 3, you presume that there's no lymphatic vessels. But how do you know if the ICG is only able to see up to 1 centimeter, what happens underneath that 1 centimeter? And this is where the modalities of using MRI really comes in to show you whether or not there are deeper lymphatics beyond the reach of the ICG. But however, MRI has the limitation of knowing exactly where it is. And this is where ultrasound really comes in to provide value in the overall examination of the for the lymphatic system that we need to use for the LVA. Now, the best thing about the ultrasound is that it really tells you exactly where that lymphatic vessel is. Once you start to practice and understand which structure is lymphatics, it not only tells you which part of the skin it's on, but also exactly what depth it is. And not only that, you're able to actually map out the diameter of the lymphatics as well. And sometimes, if you look very carefully, you could actually see the lumen within the lymphatic vessel, and that actually shows that it's a patent functioning lymphatic vessel. So with ultrasound, you're able to see anatomy and also predict the function as well. And not only that, in addition to knowing where the lymphatic vessel is, you also get to map out the vein as well. So we're able to map out, as we trace along the lymphatic, we're able to map out where the closest vein is, and able to basically know underneath the skin where that vein is closest to the target lymphatic vessel. And also looking at the vein, we're able to see whether or not it has a lot of backflow or not. So this really allows us to have a pinpoint approach on which part of the skin we're going to excise. So the question is, what kind of ultrasound do we use? And the ultrasound, when it's low resolution, when it's low frequency, it means that it has a low resolution, but it really allows you to see really deep. And the most of all, and usually the definition of low frequency means less than 10 megahertz. Definition of high frequency is usually from 10 to 20 megahertz. And with higher resolution, and also, but as the frequency elevates, as the frequency gets higher, the penetration depth becomes shorter. And the ultra high frequency is frequency from 20 to 70 megahertz, and the penetration depth is sometimes limited to 2 centimeters to 3 centimeters. So you have to understand the give and take between low frequency and high frequency. So in our practice, to do perforator flaps, low frequency and sometimes high frequency is more than enough. But when you want to do lymphatics and see smaller structures, then this is where high frequency comes in handy, and ultimately better with ultra high frequency. So here we like to use hockey stick if it's a regular high frequency ultrasound, which gives you about 7 to 18 megahertz, and it allows you to visualize the lymphatics quite well. So let's take a quick look at this video here. So in this type of patients where we inject ICG, this is linear pattern in stage 1 or maybe early stage 2. So it's very easy to see. And as we're using this hockey stick probe with high frequency ultrasound, we're able to exactly know where the lymphatic vessel and the vein is. And with the color mode, we're able to see which uptakes the color, which is probably the vein. And when it doesn't, and if the lumen stays hollow, then that's the lymphatics. Here is a patient with a stardust pattern in the stage 3. And in this kind of pattern, we also use the ultrasound. And sometimes we do see lymphatics, but we may not see lymphatics as well. And if this information overlaps with the MRI, showing that MRI also has no lymphatics, then the chances are this patient will have to undergo liposuction. So this is a very accurate way of having a preoperative staging diagnosis. And finally, even if it's stardust pattern, with the ultrasound, we're able to frequently find the lymphatics. And this is why it leads us to understand better. And usually in these kind of stage 3 or late stage 2 patients, where the ICG is only able to penetrate maximum 1 centimeter, we're able to actually see the lymphatics in that by using the ultrasound, and then go ahead doing an LVA. Now, using an ultra high frequency ultrasound is more amazing. You get incredible images. Here, with courtesy from Aki, my good friend, you could actually see exactly where it is. You could actually see the patent lumen, and sometimes you could actually see the peristalsis of the lymphatics in early stage lymphatics, as you can see here. So with the 70 megahertz, you're able to see more finer, definite, functional anatomy. Same thing here. This is using a short axis, 48 megahertz, and again with 70 megahertz. And in this case, we're able to even see the valve of the lymphatics. So it's incredible what kind of imaging it gives you. And again, not only look at the lymphatics, but also map out the vein at the same time, giving you the exact pinpoint location of where to go. Of course, there are challenges in using ultrasound. It's a user dependent, and there is a learning curve. So you have to basically use the probe and be comfortable and know what is lymphatics and how you detect the lymphatics. And of course, there is a minor cost issue. But nevertheless, the high and ultra high frequency ultrasound really allows me to locate the ideal lymphatic vessel, locate the closest ideal vein, and really allows me to plan an accurate preoperative planning that really allows a highly efficient operation and really minimize the time and the cost. So in real practice, using this kind of high frequency and ultra high frequency ultrasound allows us to do an actual functioning or functional LVA. And we're now truly doing this, implementing these kind of concept, especially in more advanced stages, lymphedema, such as stage 3, showing that we're able to now shift the paradigm of approach and able to do lymphovenous anastomosis in advanced stage lymphedema as well. Of course, allows a huge efficiency. I truly believe that the ultrasound in the plastic surgeon's hand is the true tricorder that Spock uses in Star Trek. So with that, thank you very much for your attention, and I'll be more than happy to answer any questions.